Frog heart and human heart. The structure and function of the heart in the frog are altogether different from those of man and other mammals, but the fundamental properties of the cardiac muscle are common to all of them. Unlike the four-chambered mammalian heart, the frog heart has only three chambers, two atria and one ventricle. Frog heart. The blood is collected in sinus venosus and then it enters the right atrium. From the right atrium, it enters the ventricle where it gets partially mixed up with the arterial blood from the left atrium. The contraction of the ventricle directs the blood to the bulbous aorta, that is truncus arteriosus. The bulb contains a spiral valve which directs the venous blood to the lungs via pulmonary artery and arterial blood to the body. The venous blood, after getting aerated, is brought to the ventricle via pulmonary vein. Amphibian heart versus mammalian heart. Difference between amphibian heart and mammalian heart are displayed. Frog heart dissection. Required materials. Frog, dissecting instruments, dissecting board, amphibian ringer, dropper, myographic board, myographic stand, and pins. Dissecting instruments. Bone cutter, scissors, pointed forceps, dissection board, glass seeker, ringer solution, and cotton. Amphibian ringer. The composition of amphibian ringer solution include NaCl, KCl, CaCl2, NaHCO3, dextrose, and distilled water. Turning. Hold the frog by its hind limb with a piece of cloth. Note that frog skin contains mucus glands located over the entire body. They secrete slimy mucus which protect the delicate skin from the abrasive trauma and prevent water loss. They also make frog very slippery, so frog is held with a piece of cloth. Stun the frog by its head against the edge of table. That result in unconsciousness. Feeding. Feeding of frog is done so that the animal does not feel any pain during dissection. Note that feeding of frog destroys the brain and spinal cord to abolize spinal reflexes. The muscles are flaccid because of feeding of frog, which make the dissection easier. Hold the unconscious frog in the left hand and vertiflex its head with index finger of the left hand. Feel the depression in the mid-dorsal line where it intersects the imaginary line joining the posterior border of the tympanic membranes. This indicates the junction of the skull and the vertebral column. Through this depression, insert the feeding needle and push it anteriorly into the cranial cavity and destroy the brain by rotating the needle. Next, introduce the needle into the vertebral canal and rotate it to destroy the spinal cord. Now, confirm whether brain stem is properly pithed or not by corneal reflex. Now, confirm whether spinal cord is properly pithed or not by withdrawal reflex response. Dissection. Lay the pith frog on its back on the dissection board. Make a median incision through the skin over the sternum. Raise the cartilaginous gyphy sternum and separate it from the underneath by cutting through small strand of tissue with the help of a pair of blunt scissors. Make an incision on each side of the cartilage. Insert under the pectoral girdle the bone cutter. Keep the cutter in close contact with the bone. Divide the girdle first on one side and then on the other. Raise and cut away the anterior wall of the thorax with scissors. Properties. Cardiac muscle has got some unique properties which make it suitable for the function it performs. The properties of the cardiac muscle can be studied under two broad headings. Properties study in a beating heart. Properties study in a quiescent heart, that is non-beating heart. Most of the properties can be studied through simple experiment on the frog's heart. Properties that can be studied in a beating heart is autorhythmicity. It is the property of the heart which says that the heart continues to beat even when it is denervated or isolated and perfused in ringer solution. The capability to contract in the absence of the neural control is automaticity. A normal heartbeat with a perfect regular rhythm, the time interval between two consecutive beats is exactly the same. This is due to regular discharge from the SA node in human and sinus venosus in a frog. They are the intrinsic pacemakers of the heart or primary pacemakers of the heart. However, if the intrinsic pacemaker fails to generate impulse, the other part of the heart can take over and generate impulse. This is known as autorhythmicity. In case of humans, if SA node fail to initiate an impulse, AV node takes over the pacemaker, followed by bundle of his and ventricle muscle itself. In frog, apart from sinus venosus, the atria and the ventricle can be initiate the heartbeat. However, the pacemakers with highest frequency, that is sinus venosus in case of frog, usually initiate the heartbeat. Pacemaker activity of human heart and frog heart. Concept of strenuous ligature. Rhythmic contraction of the heart make the study of some properties difficult. In human, the rhythm originates in SA node which is embedded in the wall of atria. Therefore, it is not possible to stop the heart by blocking the SA node. But in frog, since initiator of beat is a separate chamber, that is the sinus venosus, it can be blocked by tying a knot around it. First, strenuous ligature. It is tied between the sinus and atria. The ventricle is lifted up so that we can distinctly see the sinus and atria. On tying the ligature, the atria and ventricle stop contracting temporarily. Although the sinus venosus continue to beat normally, the atria and ventricle remain quiescent for about 5 to 35 minutes. After the period of quiescence, the atria starting initiating the impulse. This impulse reaches the ventricle and the atrioventricular segment start beating independent of SV. The rate of atria beat is much slower than the sinus rhythm. Second, strenuous ligature. It is tied at the junction of atria and ventricle On tying the ligature, the ventricle stops beating although the atria continue to beat. The ventricle remains quiescent for a relatively longer time, 30 minutes to 1 hour. After the quiescent period, the ventricle starts beating with its own rhythm called the idioventricular. The rhythm of the ventricle is even slower than the atrial rhythm. After both the ligature, each part of heart, that is SV, atria, ventricle, beats separately at their own individual rhythm. Required material: kymograph, smoke drum, Sterling heart lever, electromagnetic signal marker on a stand, myographic board on a stand, frog ringer, pins straight and bent, primary key and watch. Setting up of apparatus. Set up the apparatus for dissection and mounting as in normal cardiogram. Set up the normal cardiogram with a recording speed of 2.5 mm per second. Pass a thread between the truncus arteriosus and the atria with the help of the fine forceps. Then turn the heart upward and make a loose knot. Recording normal cardiogram. Record a normal cardiogram. First stenius ligature. Tighten the loose knot between the sinus and the atria. This is the first stenius ligature. The atria and the ventricle stop beating. After some time, the atria initiate its rhythm and the ventricle start beating with the atrial rhythm. Second extraneous ligature. The second extraneous ligature is now tied between the atria and ventricle at the atrioventricular groove. The ventricle stops beating again only to resume beating after a gap, this time in its own idioventricular rhythm, while the atria maintain its own atrial rhythm. Time tracing. Rotate the drum at 2.5 mm per second speed and record the time tracing every 5 seconds with the help of electromagnetic signal marker by switching the primary key on and off. Precautions. Extraneous ligature should be tied at a proper area. Ligature should not be tied in such way that no impulse can cross the ligature. The time at which the ligature is tied should be marked on the graph. All precautions taken while recording normal cardiogram should be taken. Graph. Calculation. Calculate and compare the heart rate. In normal heart, that is without any ligature, after first extraneous ligature, that is atrioventricular rhythm, and after second ligature, that is idioventricular rhythm. Inference. The observation obtained can be explained as follows. Immediately on tying the ligature between SB and atria, the impulse from SB cannot be conducted to atria. The atria and ventricle are normally accustomed to follow the rhythm of the sinus, so suddenly they cannot take over the function of a pacemaker once the ligature is tied. Therefore, atria and ventricle stop completely. After a short while, the atria comes out of the shock, start its own rhythm, and the ventricle start following the atrial rhythm. The effect of the second ligature can be explained in a similar way. The ventricle are normally accustomed to follow the atria, which when separated by ligature find themselves in a shock. It is suddenly not ready to discharge spontaneously. However, the ventricle comes out of this shock and start initiating its own rhythm, that is idioventricular rhythm. This simple experiment explains the hierarchy of impulse generation and capability of each part of the heart to act as pacemaker, that is autorhythmicity. Heart block. Failure of impulse conduction from one part of the heart to another is known as heart block. Heart block can be categorized into complete heart block and incomplete heart block. Complete heart block is also known as third degree heart block. This occurs when there is no passage of impulse from atria to ventricles. Incomplete heart block can be further subdivided into first degree and second degree of heart block. In first degree heart block is when all the impulses from atria reaches the ventricle, but it takes longer time to reach the ventricle. In second degree heart block, all impulses from atria do not reach ventricle. Long refractive period. Refractive period is the period during which a stimulus, how strong it may be, fails to evoke a response. In a beating heart, if an external stimulus is given during contraction, there is no response irrespective to how strong the stimulus is. The cardiac muscle is refractory throughout the contraction. The reason is that the cardiac muscle has a long refractive period. Since the mechanical activity is almost over at the end of the action potential, it cannot be merged. Hence, unlike the skeletal muscle, the cardiac muscle cannot be titanized. Titanization of the cardiac muscle would have lethal consequences, so the fact that the cardiac muscle cannot be titanized is a safety factor. Extrasystole and compensatory pause. During the relaxation phase, the cardiac muscle is in the relative refractive period. If a sufficient large stimulus is given during this period, an extra contraction response occurs. This is known as extrasystole because the contraction appears earlier and extra than the normally expected contraction. The next normal impulse arising from SA node or sinus venosus in frog fall in the refractive period of the extrasystole. Hence, the natural impulse is ineffective, giving rise to a pause called the compensatory pause. The beat following the compensatory pause is greater than the previous normal contraction. This is called post-extrasystolic potentiation. This is due to increased availability of intracellular calcium and is independent of ventricular filling, since this is also seen in isolated cardiac fiber. No more. Extrasystole is not uncommon in real life. It may not be always pathological. Normally, myocardial cells do not discharge spontaneously, or if they do, pacemaker discharge of SA node sinus venosus in case of frog is more rapid than the His bundle and Purkinje system. In abnormal condition, the myocardial cell may discharge spontaneously, which increases the automaticity of the heart. If the ectopic focus discharges once, the beat is generated result in a contraction before the next normal beat from SA node, transiently interrupting the cardiac rhythm. The extra beat due to the ectopic focus is known as extrasystole. Now, if the normal impulse from SA node reaches the heart, it is still in the refractive period. Following depolarization from ectopic focus, however, the second impulse from the SV or SA node produces a normal beat. This is why a premature contraction is always followed by a pause called the compensatory pause. Difference between atrial extrasystole and ventricular extrasystole. Required material: primary key, Dubas-Raymond induction coil, electromagnetic signal marker on a stand, short circuiting key, thin copper wires, connecting wires, chymograph, smoke drum, Sterling heart lever, myographic board on a stand, frog ringer, pins straight and bent, and watch. Setting up of apparatus. Set up the apparatus for dissection and mounting as in normal cardiogram. Make primary circuit in series by connecting the low voltage 6-volt DC to primary key, primary coil and electromagnetic signal marker. Connect the secondary coil to the short circuiting key. The electrode used in the experiment are a pair of thin copper wires with insulation removed from both ends of the wires. Connect one end of wires to the two inner terminals of the short circuiting key. Wrap the other end of one wire round the ventricle and connect the end of the second wire to the head of pin used to hook the ventricles. Recording of cardiogram. Record a normal cardiogram at a drum speed of 2.5 mm per second. Stimulation of heart. Put off the short circuiting key and apply a stimulus to the ventricle by putting on the primary key. Give a single stimulus to the ventricle to the contracting heart during systole, early diastole and late diastole and record the effects. Simultaneously make the point of a stimulus with the electromagnetic signal marker just below the graph. Precautions. After removal of pericardium, ringer solution should be applied regularly to prevent drying of cardiac tissue. While hooking the apex of ventricle, the pin should not pass through the cavity of the ventricle. The base of the heart should be fixed to get adequate amplitude of the contraction. To get maximum contraction of the heart on the lever, proper tension should be maintained on the thread. The stimulus applied to the heart should be threshold value. Strong stimulus will damage the cardiac tissue. The point of stimulus should be marked below the graph while recording. Graph. Result. When the threshold stimulus was given during systole and early diastole, there was no response. When given during late diastole, the heart responded with an extra contraction followed by a pause. Inference. Long refractive period. The heart muscle has long refractive period. The duration of ARP about 200 millisecond and RRP is about 50 millisecond. The duration of mechanical response is 300 millisecond. Therefore, in cardiac muscle, the mechanical contraction is in its late relaxation phase at the end of relative refractive period. The prevent detonation of cardiac muscle, which otherwise would have lethal consequence. Hence, when the stimuli are applied in the systole and early diastole, no extra contraction is observed. Contraction is only observed when the stimulus is given in the late relaxation phase or after 1/3 relaxation is over. When the ventricle is stimulated in the late relaxation phase, the heart contracts. The contraction comes earlier than the normal contraction from sinus venosus. Therefore, it is the extrasystole. The next normal impulse coming from sinus venosus finds the heart in the relative period of the extrasystole, hence fails to give a response. The pause that is observed is known as compensatory pause. The following next contraction is stronger than the previous normal contraction, called the post-extrasystole potentiation. This is due to increased availability of calcium ions. Effect of temperature on heart function. Increased body temperature, as occur when one has fever, cause great increase in heart rate, whereas decreased temperature greatly decreases the heart rate. This effect results from the increase or decrease in permeability of the cardiac muscle membrane to ions that control heart rate, resulting in acceleration or deceleration of self-excitation process. Graph showing potential changes occurring in pacemaker cell, that is SA node or sinus venosus, and its ionic basis. The three principal ions responsible for the potential changes are an inward calcium current ICA, a hyperpolarization induced sodium current IF, and an outward potassium current IK. The temperature affects the pre-potential by increasing or decreasing the slope. With increase in temperature, the slope of pre-potential becomes steeper, thus increasing the heart rate. Force of contraction of the heart is also enhanced temporarily due to increased temperature, as seen during exercise, but prolonged elevation of temperature exhausts the metabolic system of the heart and causes weakness. The reverse occurs during the cold temperature when the metabolic activity decreases with lowering the temperature. When warm ringer is applied on frog's heart, the rate and force of contraction increases. If the warm ringer is applied on the sinus venosus, we observe changes only in the heart rate. If applied on ventricle, there is change on the force of contraction only. When cold ringer is applied on frog's heart, the rate and force of contraction decreases. If the cold ringer is applied on the sinus venosus, we observe changes only in the heart rate. If applied on ventricle, there is change on the force of contraction only, that is, it decreases. Required material: chymograph, smoke drum, Sterling heart lever, electromagnetic signal marker on a stand, myographic board on a stand, frog ringer, pins straight and bent, primary key, cold ringer solution, warm ringer solution, cotton, thermometer, dropper, watch, connecting wires, and scale. Setting up of apparatus. Set up the apparatus for dissection and mounting as in normal cardiogram. Recording with normal ringer. Pour ringer solution on heart at a temperature of 25 degrees Celsius. Record normal cardiogram at a drum speed of 2.5 mm per second. Recording with warm ringer. Relax the heart by bringing the lever down. Pour some warm ringer at about 40 degrees Celsius on the sinus venosus with the help of a dropper. Bring the lever back to its recording point. Record the effect of warm ringer on sinus venosus, say about 10 to 15 contractions. Again, relax the heart and warm the ventricle with the help of cotton soaked in warm ringer. Wrap it around the ventricle. Again, bring back the lever to the recording point and record the effect of warm temperature on the ventricle. Relax the heart and apply warm ringer to the whole heart with the help of a dropper. Bring it to recording point and record the effect of warm ringer on the whole heart. Wash away the effect of warm ringer by applying normal ringer. Similar steps are followed while recording with the cold ringer at temperature 10 to 15 degrees Celsius. Time tracing. Move the myographic board away from the drum. Bring the electromagnetic signal marker connecting to the 6-volt DC via primary key in series, just below the recording taken at 2.5 mm per second speed. Rotate the drum at 2.5 mm per second speed and record the time tracing every 5 seconds with the help of electromagnetic signal marker by switching the primary key on and off. Precautions. Normal cardiogram must be recorded before applying warm or cold ringers. The range of temperature should be between 10 to 40 degrees Celsius. Graph with warm ringer should be recorded before cold ringer. Temperature of solution should be taken before application on heart. Care should be taken when applying warm or cold ringer only on the sinus venosus or ventricle. The lever should be lowered to relax the heart between each graph and also during application of warm and cold ringer. Graph. Warm and cold ringer on sinus venosus only. Warm and cold ringer on ventricle only. Warm and cold ringer on whole heart. Calculation. Calculate the heart rate and measure the amplitude of contractions with the help of scale and note down the difference at different temperatures. Calculate the heart rate from the graph recorded by counting the number of contractions that have occurred in 30 seconds. Then convert it into heart rate per minute by multiplying the value obtained with 2. When warm ringer is added to the sinus venosus, the heart rate is increased. When warm ringer is added to ventricle, the force of contraction increases. When warm ringer is applied to the whole heart, both rate positive chronotropic effect and force of contraction, positive inotropic effect is increased. The reverse is true for cold ringer. Warm ringer on sinus venosus. The application of warm ringer on sinus venosus causes increase in the heart rate. The warm ringer directly influences the ion channels and increase the pacemaker activity. It enhances the activity of both sodium and calcium channels. Effect of warm ringer on ventricle. The application of warm ringer or ventricle increase the force of contraction, thus increasing the amplitude. Increase in temperature accentuate the myocardial activity by decreasing the viscosity and increasing the enzymatic activity of the myocardial tissue. There is no change in the heart rate. Interference. Cold ringer on sinus venosus. The application of cold ringer solution to the sinus venosus decreases the rate by decreasing the activity of sodium and calcium channels, which are responsible for the pacemaker activity. Cold ringer on ventricle. Cold ringer decreases the force of contraction, therefore the amplitude of contraction is less. Cold ringer temperature increases the viscosity of the myoplasm as well as decreases the myocardial enzymatic activity, leading to decrease in amplitude. There is no change in rate. Application of warm ringer to the whole heart. When warm ringer is applied to the whole heart, the heart rate as well as force of contraction increases.